Hey everybody, it's Jim Prevost with Embrace the Shake. Hope everyone's doing well tonight. I want to start off our evening with a few announcements. I'd like to shout out to Whitebeard Canine. As you know, that's Howard and Lisa Young here in Shelby. Hey Miss Becky, hey Daniel, thanks for coming on tonight. Whitebeard Canine works with our law enforcement officers, canine officers, Cleveland County Sheriff, Shelby City. They also have helped me with Moose, Rescue 22 Foundation. Colonel Ruff, thanks for coming on tonight. Penny, good to see you. Hope you and Gary are doing well. Rescue 22 Foundation provides service dogs for veterans. That's Angela Connor, John Devine, and Eric Ennis. Haley, it's good to see you. Thanks for coming on. Wow, it's been a while since I've seen you, Haley. Hope you're doing well, and thanks for taking care of the VFW. Courtney, it's good to see you. Hope you're all doing well. Hey, Gary. Applause Your Paws in Magic City K9. Dee Hout and her crowd down there in Miami, Florida. As you know, Applause Your Paws was had to take a short break because of the COVID-19 virus down here in Florida and Miami, and Dee's got it back up and running, and we're happy for that. And also Magic City K9, which is the inmate dog training program. Dee does a super job with that, teaching an incredible program to provide careers for those who serve their time in incarceration and get out. Eric Metcalf, thank you for coming on tonight. Eric is a well-known tattoo artist in North Carolina and has his place of business in Shelby, so look Eric up and please get up with him. His folks did an outstanding job on my wrist tattoo, and this is dopamine. I can't turn my wrist over very well, but that is a beautiful piece of work. Thank you, Eric. Beth and Daryl, good to see you. Derek, thanks for coming on tonight. My roommate, Bob. Got some announcements as far as some neat things that are coming on board. Excuse me. On April 30th at 3 p.m. Eastern Daylight Time. Paula, thanks for coming on. April 30th at 3 p.m. I'm sorry I'm a little distracted. I have a lot of notes to do tonight. Don, a fraternity brother and dear friend. Don and Bob are family members as well. They're starting their new webinar series, and they're in conjunction with AARP, and they're starting a new webinar series. And the first webinar series item is the newly diagnosed and to caregiver questions, question and answer period for resources, what to expect. Hey, good to see you, Ron. Thanks for being with us tonight. Appreciate your kind words. If you're planning on doing a World Moving Day walk, please look up on the Parkinson's Foundation of the Carolinas. Many of those events have gone to virtual mode, so if you want to participate, see if they've gone virtual. I know Raleigh has moved theirs to November 7th. Please accept this yawning. I can't control it. Earl, thanks for coming on. Brother Bob, love you, man. Appreciate you, Bob, coming on tonight. Hope you're doing well. Our governor has moved our window on the shelter in place, not shelter in place, but remain at home, and that's extended until May 8th. Don't question it, just do it. You got to take care of yourself. If you can't take care of yourself, you can't take care of others by preventing the spread or exposure. Had several emails this week about medications, about sleep, about exercise, and love you too, Bob. Thanks so much. Brandon, come on, thank you for being on. Want to shout out to all the folks that are supporting their parents, not necessarily financially, but getting on the phone, calling them, seeing how they're doing, coming by their house, sitting outside, and visiting with them. I see a lot of that in my neighborhood. I want to thank Sandra Camp. Sandra Camp is sewing masks. She does an outstanding job. Marianne and I ordered several. Sandra got them to us quickly, and they're thick, they're washable. The elastic for the ears is perfect fit. So, look up Sandra Camp on Facebook. She has a bit of a display of the masks that she makes, and at the same time, she's from Zirconia, North Carolina. So you have the right Sandra Camp, and she'll be able to help you out. So I want to shout out to her for just being part of what I call the Savior team, reaching into her bag of talents and trying to help other people out, and at the same time not ripping people off, charging exorbitant prices for their wares to help fight this virus. I'm going to have to look down at my notes tonight a little bit, because I have a good bit of information at the request of some folks that wanted to know about sleep disorders, medication concerns, and want to talk a little bit about exercising. And then finally, one person said that they take all these medications and they just feel rotten all the time. And I can relate to that a little bit, but now that I'm down to just one pill twice a day, it's a different story. As you can see, I'm a little fidgety tonight because it's getting close. Hey, Amanda, thanks for coming on tonight. Hope tonight's beneficial for you. Okay, here we go. First thing I want to talk about, Parkinson's disease versus Parkinsonism. It's like I said, of the folks that are in the group that I relate with, we have 100% misdiagnosis rate. And some folks say that's a misdiagnosis rate. That's absurd. That's a misdiagnosis rate that ought to be taken care of in litigation in the courts. Hey, when you got 40 different symptoms, signs and symptoms that also mirror other types of disorders, then you're going to have some cross confusion on what I call cross confusion or cross applications of signs and symptoms. As a former medical practitioner, here's an example. Person comes into the clinic and they got a swollen knee. They were running and stopped suddenly and they heard a pop. So you examine the knee and the knee is swollen and tense, and it's difficult for you to get a positive ACL test, an anterior drawer. But because of your years' experience, something feels a little sloppy in there. And then you do another test and it feels like the cartilage is clicking because it's torn. And then you have some scarfing or like a rubbing sensation and you think, wow, they got a tibial plateau injury. So you've got three things that have shown up. So now you have differential diagnosis. So you send your client, your patient on to the doctor finds some of the same stuff. They send them off to the MRI, and the MRI says, no ACL, yes meniscus, and a contusion to the tibia. So your patient comes back and is angrier than all get out because they didn't have an ACL like you thought. Well, okay, $4,500 for a meniscal repair or excision versus about $13,500 for an ACL. They ought to be thanking you for the process that you went through, and then, find out what's up. Thank you, Bill Wiley, that I'm looking good. You notice I got a little bit of an Elvis look tonight. and finally put some weight back on. So I'm good to go through. Hope you're doing well, Bill, and your lovely family. All right, now the Parkinson's and the Parkinsonism. Here's where they match. There's both have tremors. They both have stiffness. They both have bradykinesia, where you slow. Okay. Sometimes they have some spasm, correlated spasm. Here's the big difference. Parkinsonism usually affects both sides of the body. Usually rarely is it hemispherical, one side. Okay. Hey, Jimmy Martin, good to see you. Joey White, thanks for coming on. So if you have somebody that presents to the clinic, presents to the physician, and they're trying to make a diagnosis the first time around, then they may label you, target you, or Parkinson-like or Parkinsonian or Parkinsonism presentation. That means you have some of the Parkinson stuff, but you don't have all of it. Okay? So then they send you to the MRI, and the MRI is looking for protein clumps in your brain. Got it? All right, so then you have the MRI that comes back and typically has a T1, T2 lesion in your brain. How can you tell if you have a ruptured disc? I can get to that in just a minute. Okay? So then you say, well, I've got this lesion in my head, this marker in my head. It's a protein buildup, then I must have Parkinson's versus Parkinsonism. Well, some research I just read says that in some folks with Parkinsonism, they also have protein buildup. And this is where I've got some exciting news, okay? So again, you're kind of along that tether of Parkinson's versus Parkinsonism versus Parkinsonian. All three respond to dopamine. All three do pretty well with dopamine initiation for a period of about 6 to 8 weeks. A lot of times they do well all the way, okay? Years down the road, you're looking at them. And then all of a sudden they came up with this thing called a DAT scan. I don't mean like yesterday, but now insurance companies are starting to pay for it because they found out that there's a better way of diagnosing it just in clinical. Let's get into the brain and see if there's any protein clumps. And these clumps inhibit the dopamine distribution. So you got dopamine in your brain, you want it to go throughout your body to do its thing, but this protein's blocking it. So they do this DAT scan, they put radioactive dye in you, and you sit for 5 hours or just go do something else. And you go back and you're in the scan for an hour, and then they find all these markers on your head. That's where they can be a separator. So you go back to your doctor, you present the clinic again, he goes, great news. You don't have Parkinson's disease. It's like lifting a death sentence off your back, okay? Because life as you know it with Parkinson's disease does this. Down. Life with Parkinsonisms do this. A lot of times the Parkinsonisms get to a point of presentation that they don't get a whole lot worse. I like that, whole lot. They don't get worse. They usually stay within what they call the realm of presentation. They may digress, but they don't become super debilitating. They don't become debilitating. Where Parkinson's can become debilitating. I'm not saying it has to. So all of my listeners that have Parkinson's, okay, when we got told that 40 years ago, 20 years ago, we'd have been in our mindset of death sentence. And now what we get is, I got to suck it up and drive on. All right, and that's what the group that I am with, that's what they do every day. Every single day. They suck up and they drive it on. They embrace the suck. Okay? Like I said, the tremor, the bradykinesia, okay, slow movement, the tremor, okay, the stiffness, the soreness, and the pain, Parkinsonism and Parkinson's mirror each other. The separation is how well you respond to the dopamine, how well you respond to the inhibitors, and how well you respond as far as clinically if you start to digress or you develop secondary signs like dystonia, sleep issues, loss of taste and smell. Parkinsonisms, you usually don't have that, okay? And here's the other one that's going to throw the curveball, okay? That you just have a touch of Parkinson's, but you're mainly Parkinsonian or a Parkinsonism patient, all right? Like, I don't smell and I don't taste. I even had some hearing loss, but that's military related, I'm sure. But those are the defined markers, okay? I have Griffin's claw hands in one, hemispherical, but not the other, okay? This is Griffin's claw position, and this is chorea position, C-H-O-R-E-A. See how they can be confused? This is also dystonia. This is also chorea. And this is also clonus, which you're seeing. All of those can be confused. Okay? What I'm trying to say is, as the disease progresses from Parkinsonism, if the disease progresses, then they have to start looking at Parkinson's. The fight is the same. The medications are very similar, but you have now a better brand of diagnostic tools and diagnostic medications that will help the Parkinson's patient better, okay? You have dystonia and sleep issues, but much better with a full dose of Cinnamate. Very good. Amanda says that she takes Cinnamate. I took Cinnamate for 3 years, okay? And the pain did much better. Here lately, let's say in the past 6 months, hey, Vaughn Coleman. Vaughn and I went to college together, a lovely Southern lady. I got to the point to where I couldn't take my medications because they were making me sick, and I was in that transition time. So Brad Gardner, my primary care provider, genius, that's all I'm going to say. He said, I want you to try Cymbalta. And I'm thinking, oh Lord, here we go. We're going to do Cymbalta, and we know Cymbalta is it's for anxiety, okay, and depression. But there was a study done that said that it helps with Parkinsonian-related pain, okay? It's also used for chronic pain. So we did the chronic pain dosage and somewhat successful. But I read another study that says it doesn't work. So here's my point that I'm trying to get to, is that your medications have to be specific for you. And that noise you hear is that moose. But at the same time, when they're specific to you as a Parkinson's patient, a person with Parkinson's, okay, PWPD, person with Parkinson's disease, okay, whether it's Parkinson's disease +1 or whatever, you have got to be knowledgeable about what you can take and what you cannot. So this is what I wanted to do tonight. I wanted to help you, okay? Here's one big thing that we have now, you see on television, okay, about hallucinations, illusions, and behavioral changes. So they have a medication for that. They've got medication for everything. The bad problem is that some of the Parkinson's medications cause hallucinations. Hey Vicki Murray, good to see you. My sister Karen's on, okay? Thanks for being on, Karen. Some of those medications bring on psychosis. So how do you feel as a physician? I have this patient's got obvious PD signs. He isn't sleeping and yada, yada, yada. And I provide this medication that reduces Parkinson's disorder, which it helps. But now it's created a sleep psychosis with that medication. What do I do? Well, there's some medications that they can give you that are not dopamine blockers, because what happens is these medications sometimes cause dopamine blockage. They might be for anxiety or other medications. But Clozaril and Seroquel are dopamine blockers that do not make the PD symptoms worse, okay? What they do is they kind of get around that, and they work with the neurogenic disorder generated sleep disorder. Here's another little dandy, okay? Another little dandy is there's a medication called Klonopin, okay, which is an anti-seizure medication. Klonopin, also known as clonazepam, is usually given in a half dose twice a day, half milligram. And that medication reduces spasm, and it reduces jerking, and it reduces pain. And at the same time, those are the things that wake parkies up in the middle of the night. It also helps relax the muscles, so the dystonia, the cramping, you don't want cramping in the middle of the night. The cramping is reduced. So now you get a better tone of sleep. Here's the thing, okay? What if I told you that in a recent study, it said that sleep disorders was one of the most commonly ignored clinical signs of folks that are in the pre or the initial stage of Parkinson's, okay? That'd blow your mind. Hey, Brandy Hardman from Limestone College, our beloved president's executive assistant, direct line to the president. Brandy does a super job. George Paradis, I went to high school with George. Thanks for being on tonight. And this was a study, and this kind of ties back in because there's some folks out here that have sleep disorders, okay? And here's the thing, folks. If you sit down and have an honest discussion with your neurologist, if you can keep them pinned down, and you tell them, look, this sleep disorder that I have, okay, is causing me to be tired during the day. It's causing me to have pain. I'm not doing well. I'm getting worse with my Parkinson's. Here's the catch all of that. It said in the literature that I read that one cool thing about our body it does is that when we sleep, our body regenerates the brain to attack negative enzymes and negative proteins, thereby blocking them and destroying them. They just happen to be the same enzymes and proteins that are seen in the first stages of Parkinson's disease, the identicals, okay? The thing about it is that if you're going to your PCP, primary care physician, and you're having sleep disorder, the first thing a lot of times they want to do is a sleep study. Good to go. But how about having them channel you to a neurologist that also does sleep study stuff? So if they do a sleep study, then they can observe you and your brain waves, and at the same time, they can see what periods of that is and if it's blocking your REM sleep. And at the same time, they can go ahead and determine maybe we need to try this instead of waiting a while. And then they can introduce a sleep schedule, a sleep medication like Klonopin, which is an anti-seizure medication, and they can introduce that co-introduce medication with a sleep program, which needs to be also a diet high in hydration. Combine all those nutritional, combine all those sleep schedules, and combine that medication. And hopefully, and the study shows this, that the Parkinson's disease process started to slow down. The motor patterns in the people with PD and Parkinsonisms got better. The motor speed, the abilities to reach, the abilities to close hands, the ability to not have dystonia as bad. So that study is out. It's a hot number study right now, meaning that it's being pushed through the research realms as far as funding, because there were such promising outcomes in the first measures of the study. So hopefully we'll see that new type of therapy for Parkinsonism, medication, diet, sleep schedule, exercise schedule, daily routine schedules, and integrated medicine effect. This study was very solid, okay? So I've talked about PT psychosis a little bit, rambled on that, and then talked about the sleep. Here's the other thing. Folks that presented sleep disorders to their physicians and were treated for a common sleep disorder. When dopamine was introduced into the sleep disorder program, they noticed a diminishing of the sleep disorder problem. And then they noticed an acceleration, okay? And what happened is that then these people were referred to neurologists and movement folks, and guess what they found? That's a mic drop moment. So when you go to your doctor, sit down and have an informed talk with them about a medication, sleep plan, nutrition plan that they can design for you to help you with your Parkinson's-related sleep disorder. All right, common medications. These are common medications that we get, that we see, that are used, that we, you, and folks like me with movement disorders have to be really cognitive of, that we can't use because of our Parkinson's medications or our movement disorders medications. All right, so let's talk about those really quick. You have Compazine, Phenagrin, and Reglan, okay? Can't use them. Those are GI drugs used for motility, okay? So they have to use an alternate medication that if you have Parkinson's and you're taking the dopamine medication, okay, or a serotonin medication type of an uptake medication. So they have to use Zofran for the nausea, and they use erythromycin for the motility issues, the infections of the gastrointestinal tract. There's also noticed that Risperidone and tetrabenazine were medications that made Parkinson's disorder significantly worse almost immediately, okay? If you want a list of these medications, please contact me through Messenger, and I'll get that to you. And then what you can do is take a picture of that and put it in your phone, so if you present to the ER, you can tell them, here's what I can't take because I take my PD meds, all right? The nice thing about that is that they have Zofran as a medication that you can use if you have a lot of nausea issues, and it works well with the Parkinson's medications, and it doesn't have any true side effect interaction issues. The same with erythromycin. It doesn't have a negative response to hardly any, if any, of the medications for Parkinson's. Antidepressants, anxiolytics, and mood stabilizers, and thyroid medications. And you have to be really careful. So if you're taking Cymbalta, okay, which is an anxiety depressant medication, and also used for a lot of other things. If you're taking Lactrimol or any Synthroid or Novast, for hypertension and Novast, please tell your neurologist. I know he's going to read your chart, but if you're presenting to the neurologist the first time, make sure that they know that you're taking these so they can help guide them. If you're taking any of the MAO inhibitors, please also be careful as well. Taking Parkinson medications, Therefore, you don't have a co-reaction or a synergistic reaction where the medication heightens in its ability to do its job and it causes you an issue. All right. I want to get back to that sleep disorder thing really quick because I got a little bit of a text here. Okay. What's good about the Klonopin is it's really targeted. Like I said, it's an anti-seizure med too. It's really targeted to REM sleep problems. Okay. Such as sleep behaviors to where the individual that has a sleep disorder is acting out their dreams. And they're very vivid, okay? Some would toss that off to combat veterans, law enforcement, EMS, and fire, medicine, whoever has PTS or PTSD, whatever you want to call it, whatever area you're from, would say, oh, that's just their PTSD coming back. So we're going to, get you to some counseling. Great idea. But also look at the fact that maybe a medication may help as well to work alongside that counseling, but also work alongside to help restore the sleep pattern. And a lot of times if somebody's sleep pattern is restored and they are getting deep sleep at night, they can pull them off the Klonopin gradually and they have a positive result. They don't have to go back on it. Okay? So I talked about that medication a couple times in the sleep disorders as well. The final thing I want to talk about is exercise. All right, and Rock Steady Boxing has the ear of the PD Foundation because it is a fact that boxing does help Parkinson's, and it really doesn't matter what stage it is. You use the Canadian scale or you use the U.S. scale. Boxing is outstanding. And the people say, well, why? Well, it's exercise. It's progressive overload, which means it gets harder each time. You can use a DAPRE effective, just a daily adjusted progressive resistance exercise, and it has all these benefits that are very scientific. Here's what it really does. Boxing, mixed martial arts, Krav Maga, Jeet Kune Do, which is Bruce Lee's style. All of those styles require such a kinetic firing mechanism, a chain reaction, a chain fire, that it helps restore that function lost by a movement disorders patient. It is a fact that if you create chaos in the muscle bundle, chaos in the sarcomeres, the little things that make muscles move, if you create chaos in the neurological fibers, then you spark that muscle fiber to have to work to figure that out. What's going on? The same with the neurofibers. They get sparked. What's going on? We got to figure this out. So as they're both trying to figure these out, okay, while they both figure these out, that kinetic chain starts to fire like it used to, just a little bit. But the whole idea is if you captured that, then you maximize on it. So let me give you an example. Somebody that has freezing in the upper extremities, they're tremoring like this, and then as they exercise, the tremors get so bad, the freezing gets so bad, they lock up. They freeze. So what you do when you see that in boxing or whatever, if you're the caregiver, a friend, you immediately get your hands on them, okay? Grab a hold of their wrist, get your hand under their elbow, and start stretching. Now you're going to create a chaos. Wait a minute, I was just frozen. I don't want to do this anymore. I'm locking you down. And you're saying, yes, you are. Yes, you are. Well, what's happening here? I don't understand. Let me figure this out. The muscles try to figure out what's going on. So it's dumping a bunch of enzymes and proteins. The neurological's doing the same. And next thing now, you got this chemically induced muscle, and then all of a sudden the freezing goes. And they can rejoin the exercise, and a lot of times the range of motion is better. The muscle's been heated up. The chemicals and proteins, the calciums, magnesiums, all those EMs, okay, are now being pulled from the latent state if they're not totally diminished. And now the range of motion is better. The bradykinesia is less. Wow, that stuff really works. And then it has a 24-hour effect off them. Okay? So that's why boxing works. Training in martial arts works. It calls into use what has been taken out of use by the disease process. That's why you gotta keep moving. Now you're gonna have bad days and good days, okay? But all in all, if you'll keep moving and you'll work every day, and all it takes is 20 to 30 minutes tops. And if you want to work 15 minutes, 20 minutes in the morning, and then 15 minutes, 20 minutes in the afternoon, and at night, moving, you're going to slow things down. You're not going to stop it, but you're going to slow it down. They got this information and idea from working and understanding the process of cerebral palsy and what it does to the tetany or the tone of the muscles. And they got this from studying people that had dystonia. And they got this in studying people that had muscular dystrophy. And then they put these confusion theories together, and they saw improvement in all those studied populations. So the carryover is wonderful. And I applaud Rock Steady Boxing for what they're doing. That's where the big program got their ideas from, those studies. So one more time, if your body is in a frozen mechanism or it starts to have a shorter range of motion, then the only way to take care of that is override the muscle pattern by using quick movements, explosive movements, and repetitive movements. This creates a chaos in the new normal kinetic chain and helps restore the way the kinetic chain used to be. Kinetic chain means movement chain. There's a certain set of events that have to occur for movement. I hope that's a okay understanding. The whole idea is keep moving, keep those extremities moving, keep your posture straightened up, work hard, follow your plan, take care of yourself, rely on your friends, eat right, work on your personal stuff. Hey Heidi, Steve, thanks for coming on tonight. What I mean by personal stuff is your personal care, mindset, body, hygiene, nutrition, and spiritually and emotionally. All right, folks, that wraps it up. Thanks to everybody that's been the support in my life. I appreciate you. Tomorrow's my last class day at Limestone College. I'm very sad about that, but life's events have determined that need to be more focused on this disease process, and just it's time to retire. It's time to stay home. And I've enjoyed my 2 short years there as a faculty member, and as a full-time faculty member, I've done some adjunct stuff, doing online now. But it's been no greater. I've had no greater honor than to go back to my alma mater, and the one that gave me a start. And now I'm stepping into a different chapter. Okay, I'm honored to be a saint. Limestone College is my college. In effective July, it'll become Limestone University. So our seniors that are graduating this year are the last of the Limestone College graduates. We are a unique group of individuals, and they should cherish that and honor it and be proud of it. I want to thank EMS, fire, law enforcement, all of our healthcare workers, all those working in mercantile to provide us what we need, the unsung heroes of the highway, the freight haulers. Gosh, you could go on and on. We are the greatest country in the world. God bless our country. Y'all take care, and always remember, embrace the shake.